Next, can I help him with that one, please? Question 8.
A 70-year-old man is evaluated for a 3-week history of mild headache, cognitive impairment, and right-sided weakness. He's been previously healthy. His score on many mental state examinations, 20 out of 30. A slight right lower facial weakness and mild right hemiparesis, and there's mild expressive language difficulty. There's no palpable edema or neck stiffness. MRI of the head with gadolinium shows a 2-centimeter homogeneously enhancing lesion in the white matter adjacent to the left lateral ventricle. There is a second homogenously enhancing 1-centimeter lesion within the brain adjacent to the fourth ventricle. Both lesions have mild mass effect, but there is no midline shift or ventricular obstruction. The radiographic appearance is considered to be most consistent with central nervous system lymphoma. CT of the chest and abdomen is negative for tumor.
So by the way, when you see these on your board, the homogeneously enhancing lesion on MRI is two things. It's either CNS lymphoma or toxoplasmosis. So which one is the most appropriate next step in the patient's management?
You said homogeneously what?
Homogeneously enhancing lesions. Enhancing, like on the T2 phase images, when they give gadolinium, it looks like enhancing lesions.
And it suggests what?
It's lymphoma, CNS lymphoma, or toxoplasmosis. So let's say this person already has lymphoma. How do you treat lymphoma in the brain? They treat it with steroids, radiation, and methotrexate. That's how you treat it. But anyway, so patients with primary CNS lymphoma, they can present with, like this case, like patient is confused, memory loss, focal neurological symptoms, and or seizures. On MRI, you can see a single lesion versus multiple brain masses, and you have to complete the evaluation by doing a good eye exam. So you always call the ophthalmologist when I have a patient with this. Call the opto resident or the opto attendant just to do a good fundoscopic exam to see if there is a distant disease or involvement in other areas, and you very commonly you have to do a brain biopsy because just based on imaging you're not 100% able to differentiate whether or not this is toxoplasmosis versus CNS lymphoma. However, things that may help the physicians to make a decision is by looking at the peripheral smear or even looking at the bone marrow biopsy, because that way you can actually have tissue in a less invasive form. And not every hospital has neurosurgery, so that's another consideration. And I think neuroradiology IR is the one actually doing these biopsies nowadays, but again, it's only reserved to tertiary or teaching hospitals, tertiary institutions or teaching hospitals. Okay, so the way we treat it is with methotrexate, whole brain radiation therapy, and steroids when they have like symptoms like compression symptoms. Toxoplasmosis encephalitis is similar. Like I said, this patient have a seropositive IgG antibody. They may have an IgM if they have enough time to mount an IgM response. If your patient has HIV and a CD4 less than 100. They need to be on prophylaxis against toxoplasmosis. You guys know what medication they use? I'm sorry? No, rifampin is for TB. They either do trimethoprim sulfa or they do atovaquone. Atovaquone is the other medication that they use. Another thing that points more towards like toxoplasmosis is that if the eye exam is suggestive or they have multiple brain-enhancing lesions, whereas if you have a few, it's probably more likely lymphoma. But you start treating them, you don't wait for the pathology, you start giving them like pyrimethamine and sulfadiazine, and you call the neuroradiologist to just get a sample. But you definitely have to do tissue diagnosis. Okay, can you please help me with question number 9?
A 72-year-old man is evaluated in the emergency department for generalized weakness since falling earlier this morning. He did not lose consciousness but fell forward, hit his chin, and he was unable to get up. Mental status and cranial nerve are normal. He has a 3 out of 5 weakness in the arms and legs bilaterally. Pinprick sensation is diminished in the arms and vibratory sense is severely diminished from the knees down. Reflexes are brisk 3+ in the upper and lower extremities with a bilateral extensor plantar reflex. Which of the following is the most appropriate diagnostic study?
Looking at like a 72-year-old guy with multiple nerve involvement, right? So 3/5 weakness in the arms and legs bilaterally, and sensation is diminished. So what do you want to do with him? What do you think he has? When do you measure the serum CK, creatinine kinase? You measure it if you think about like a myopathy, right? That's basically what neurologists do. They do muscle biopsies to rule out like primary muscle disorders. But this person doesn't seem to have a muscle disorder, right? It's more like specific to certain MRI of the cervical spine. Okay, so this person, compressive myelopathy, patients can have bilateral motor or sensory dysfunction like this person with nothing in the brain, no brain or any brainstem findings. They need to be evaluated with an MRI of the spine, and they need to be ruled out for epidural abscess. And which patients get epidural abscesses, by the way? Is an epidural abscess an emergency, or do you guys think it's something that can be managed as an outpatient? So IV drug users get epidural abscesses. Also subacute metastatic sites of infection. Let's say somebody with subacute endocardial endocarditis, subacute and bacterial endocarditis. They can actually throw emboli and cause metastatic infections. And one of the manifestations, if you ever encounter a patient with bacteremia, particularly MSSA or MRSA bacteremia with back pain, that needs to be addressed and that needs to be worked up very aggressively. The reason being is that the first phenomenon is discitis. It's actually osteomyelitis of the spine. And if you don't treat it, it can progress towards an epidural abscess. If you have an epidural abscess, that's a neurosurgical emergency. Patients will become paraplegic if you miss the diagnosis, or they can even die if the lesion is high up enough. So I'm going to share a case when I was at Oliveview. There was a woman who was a frequent flyer to the ER. She was a pain seeker, and she was an IV drug abuser. So the lady went in. She complained of severe back pain. She got whatever morphine that they gave her. The lady left the ER by foot. She was walking on what's the name of that? Roxford Street. They found her, like she passed out. The police found her and they took her back to Oliveview. And the lady really had no reflexes and there was nothing on the neurological exam. They sent her for an MRI, and she had a very large epidural abscess, and she became paraplegic, and it was a lawsuit to the county, and she was able to get like a couple of $1 million from an epidural abscess. So my teaching point for you guys, if you have someone with bacteremia, either because they have a central line, an abandoned central line, or endocarditis, or like pretty septic, if they have back pain, you need to pursue this. And the way you do an exam is you palpate the vertebral bodies with your fingers one by one. And patients with discitis, it's not like I have a little bit of pain. They will jump out of the bed. If actually they have inflammation of the vertebrae, immediately will jump. They will scream at you. And the imaging of choice, if you don't have advanced kidney failure, you do an MRI with gadolinium, just to look at an epidural space. If you cannot use gadolinium, by the way, do you guys know why we don't use gadolinium in advanced kidney disease?
Clogged up the kidney.
No, it's actually contrast. You're talking about the iodine, the radio contrast. But I'm talking about gadolinium. Do you guys know why we cannot use gadolinium if the GFR is less than 30?
Is it toxic?
It's toxic, but not to the kidneys. What happens if you give gadolinium to somebody with renal failure? There's a condition called nephrogenic systemic fibrosis. Have you guys seen pictures of NSF? So I recommend that you guys write it down somewhere and then you look it up. because it will be on your boards probably. It's a condition that the gadolinium does not get excreted by the kidney. It deposits in the subcutaneous tissues and it causes like a cascade of inflammation and fibrosis. And the patients actually can have generalized fibrosis, and it can be lethal over the period of years to decades. Fortunately, it's rare. Not everybody that gets gadolinium will develop it, but it's generally accepted that if the GFR is less than 30, I don't think there's a radiologist here in the U.S. that will give gadolinium. Even if you order it, you're the prescribing physician, the medication needs to be dispensed by the radiologist, and all radiology techs and radiologists, they know that they're not supposed to do it if the GFR is less than 30.
What was the name of that?
And nephrogenic systemic fibrosis, NSF. So I want you to look it up and look at pictures. Fortunately, we don't have that many cases. I think worldwide, probably like 100 and something cases worldwide. But it's on the boards. You may get a question about that. Okay, so if you have a compressive myelopathy, you need to treat these patients with steroids, very quick surgery. If you have a tumor or an abscess, the abscess needs to be drained, the tumor needs to be resected if possible. Okay. You're next, my friend.
Healthy and active and returned 1 week ago from a camping trip in Colorado. On physical exam is awake but is confused and oriented owing to person, severe headache, myopathy, temperature 38.7, pulse rate 98, respiratory rate 22, blood pressure 138 to 92. There is moderate nuchal rigidity with no neck masses or carotid buoys. Cardiopulmonary and abdominal exam are normal. Mild pain is elicited on deep palpitation of thigh and calf muscles. On neurologic exam, the cranial nerves are intact. Gait cannot be tested. Muscle strain is markedly diminished in the lower extremity, somewhat reduced in the upper extremity. Sensation appears to be intact, but the patient has difficulty cooperating with the exam. Deep tendon reflexes are absent throughout. Plantar reflexes are flexor bilaterally. Labs, hemoglobin 13.7, hematocrit 41%, leukocyte count 11,200, platelet count 210,000, buns 19, creatinine 1, serum aminotransferase normal, urine analysis 3 to 5 leukocytes, and 1 plus protein. CT scan of the head shows no lesion, lumbar puncture is performed, CSF fluid kinase are followed, opening pressure 310, protein 105.
Is that opening pressure high or it's low?
That's high.
It's pretty high.
Glucose 59, gram C negative, culture no growth. Patients hospitalized, empiric acyclovir is begun 1 day later. MRI of the head shows mild meningeal enhancement without parenchymal lesions.
Parenchymal lesions. Okay.
Lesion falling is most likely diagnosis.
Yeah, HSV. So this is a classic distribution of HSV in the MRI. Dengue fever, very unlikely to cause encephalitis. I don't know if we have dengue fever in the U.S. I actually had dengue fever myself. It was pretty awful. But pneumococcal meningitis. These patients, the distinction is that the patient with meningitis is not altered. The patient with encephalitis is pretty altered. So that's one of the ways that you use to differentiate what they're asking me. What is it that they're asking me? If it's just meningitis, they may have all the symptoms like that you described, but this person was pretty out. And then the progressive multifocal leukoencephalopathy, I think you only see that in patients with immunosuppression, like advanced immunosuppression. I forget what the name of the virus. I think it's the JC virus. Yeah, the JC virus. Okay, so symptoms of encephalitis, classic altered mental status. You're not going to have encephalitis if you're with it, period. And profound, and by the way, West Nile, it's here in LA, many cases every year. In every hospital, we treat a lot of West Nile. One of the interesting things that happened last year is that 3 of my dialysis patients, they presented with severe altered mental status, and 2 of them died from West Nile encephalitis. and the diagnosis it needs to be sent to the state lab. You send the encephalitis panel to the state lab because it's not cost effective for the hospitals to maintain the resources to be able to run like these 17 different serologies that they do like for many Japanese encephalitis, Venezuelan encephalitis. They have like all sorts of like viruses that they're very rarely seen, and the result, it takes about 3 to 4 weeks to come back. But we do have a serology for West Nile that you can actually send the CSF for West Nile antibodies, and that's pretty diagnostic. The problem is we do it just for collection reasons because there's no treatment for that. Like this disease can actually be it can vary from no symptoms, it can vary from very mild indolent presentation to pretty profound altered mental status and death. In my career, I've seen probably like 5 or 6 patients dying from West Nile encephalitis. And you guys know we get it from a mosquito. It's a vector-borne disease, and it's usually in birds. So if for whatever reason you guys get a dead bird somewhere, do not touch it. Just wear gloves or something, but because that's one of the natural reservoirs for West Nile. But we do have it in California, unfortunately. So typically for HSV encephalitis, you see the temporal lobe involvement. In West Nile, you can actually pretty much everything. But if they tell you that the enhancing areas are in the temporal lobes with altered mental status, you think about HSV, or the other possibility is the varicella zoster virus. Typically, the patients have a little bit of mildly elevated protein. It's more like when you have bacterial infections, when you have a lot of protein in the CSF. The glucose is normal. It's typically very reduced in bacterial meningitis. And the WBC count can be elevated primarily with a lymphocytic predominance. You guys know what else gives you a lymphocytic predominance, CNS-wise? I'm sorry, fungal? Yeah, fungal. What else? Like cryptococcal you're talking about? Cryptococcal meningitis, yeah. And what else? TB can actually give you lymphocytic primarily. Yeah, so, yeah, you can see red cells in the HSV. Oops. Okay, yeah, very good. So again, altered meningitis, encephalitis, non-altered is meningitis typically. All right, any questions? No? Okay, can you help me, Jonathan, with the first paragraph for the nephrology case?
Yep. You are requested to see an 80-year-old man on a surgical service because of an elevated BUN and creatinine. He had just undergone a splenectomy for thrombocytopenia secondary to splenomegaly from underlying chronic lymphocytic leukemia. Immediately before surgery, his BUN was 22 and his creatinine was 1.3. Urinalysis was normal. When checked 2 days post-operatively, his BUN had increased to 40 and his creatinine to 3. Urine output for each of the last 2 days was approximately 250 milliliters per day. I'm going to read discussion points.
Yeah, so do you guys, definition of acute kidney injury, you guys know we don't call it acute renal failure anymore? You guys know why? So most of the time it works again. So that's one of the reasons. The other reason is because it's a pretty scary term to use for patients and families. Like if I tell you your kidney is acute renal failure, you're like, oh my gosh. It's better to describe it as acute kidney injury. Same thing with the lungs. We call it acute lung injury or transfusion-related lung injury. Acute lung injury. And there are different tables and different classifications to use to define acute kidney injury. The simple and the easiest one is to use your judgment. You guys know how much urine you're supposed to make in a 24-hour, like how many mLs of urine you're supposed to make? Or we're supposed to make? Like normal kidney function?
Per day?
Per day?
Or per hour?
250.
It's usually at 1 ml per kilogram per hour. So that's normal urine output. Anywhere like from 0.5 to 1, that's say probably just 1 ml per kilogram per hour. But normal urine output in a 24-hour, just for average drinkers, is about 2 liters or probably 3 liters, depends on how much fluid you drink in a 24-hour period. So this gentleman that I'm describing, he went to the hospital for some sort of elective procedure, and his serum creatinine 1.3. You guys think is high for an 80-year-old? You think it's near normal or normal? What would you think?
It's near normal.
It's near normal. Do you guys know what happens with the classification? The National Kidney Foundation.
Turns up.
Yeah, the National Kidney Foundation, about, I would say, 15 years ago, they came up with the classification of kidney disease, and the reason why they did it was primarily to raise awareness on non-kidney providers, like advanced providers or primary care physicians, that there was something that was going wrong with the kidneys. So they end up using the equations, the one that we use to this date, and that's probably going to change in the next few years. It's called the DMRD equation, this modified renal disease diet study. And that equation gave us a number, the filtration, the GFR. And the criticism of the studies is that the studies were done in a cohort of males. Most of the patients were white males. There were a little bit of females, but most of the patients were white males with a steady diet, with a steady production of creatinine, and under no stress circumstances. So when you guys describe the GFR, it's for the outpatient setting. It's for the patients that are very stable. You describe the GFR is 55. It's always been like this. In the setting of acute kidney injury, we don't use the GFR. We don't use the GFR because it hasn't been studied, and we just follow creatinine values. And the reason why, they did that. Well, that was the reason. And the unintended results of doing that is that they ended up classifying a lot of people with a disease that they actually didn't have. And the reason is that those equations are very inaccurate for the very young and for the very old. In pediatric nephrology, I think they use a different type of equation. They don't use the DMRD because it's so inaccurate that they came up with their own equations with the corrective factors. But the bottom line is that when we have patients with 80-year-old, I get a consult about this all the time. 1.3, bland urine sediment, no protein in the urine. What else should I do? Do nothing. Just pat the patient in the shoulder and tell them that everything's fine. But so when you guys see someone with this age, with this number, the other thing is that the other important consideration with creatinine is that you have to remember that it's a muscle protein, right? So if you have a person that eats a lot of red meat, they're likely to have higher creatinines. If you have an African American with a lot of muscle mass, they're likely to have higher creatinines with a normal renal function. So, and the other thing is that if you have a very frail old lady that has no muscle with a creatinine of 1.3, that lady is probably already in renal failure. So those are you have to use that information in the right clinical setting. So this gentleman, let's say that he was a normal average 80, how old did I say it was? 80-year-old male. He went in fine with his creatinine of 1.3, and something must have happened, right? Because his creatinine is rising. So what do you think could go wrong in the OR? Why do you think this guy is developing acute kidney injury?
Maybe he had a bleed and
Very good. Somebody cut him and he may have bled, and bleeding causes hypotension. And hypotension is probably the most common cause of acute kidney injury in the operative setting. But what else? What else goes wrong in the OR?
Medication.
Yeah, like medications that they may have used. So I told you that he got a little bit of Ramiro didn't print a copy for me. No. Oh, it's my phone. Let me look it
It's
up.
on we opened it on this.
Oh, on the computer?
Yeah. If you want.
Whatever. Just have it in my phone here. Okay.
it's a normal creatinine range
Depends.
for between 20 to 50 years old.
Usually it depends on your muscle mass and your ethnicity, but anything like 0.7 to 1.2, 1.3 could be normal.
And then for an elderly,
Elderly, like this person, 1.3, 1.1 to 1.3. It should be normal. Yeah. Like I'm pretty sure my creatinine is higher than your creatinine because I have more muscles than you. So, and it depends. I have an African American, his creatinine is 1.6. So I measure his creatinine clearance, the 24-hour urine creatinine clearance, and his 24-hour urea clearance, and his GFR is actually 90 something. So there's a big discrepancy, and it was all related to his big muscle mass. All right, so what else do you want to know? Like, what other historical information you want to know about this case? Like, let's say that you're the consultant. This is when you guys are rotating in the nephrology service. They're gonna send you, okay, see this. Patients, they're usually underdiagnosed and undertreated for serious coronary issues because everybody's afraid of giving contrast. And the reality is that not every patient develops acute kidney injury from contrast. I would say probably 1/3 of them. And the ones that are suffering from that, most patients actually recover. And there is a very, very small percentage of patients that they won't recover, and then those patients will become dialysis dependent. But that's not the case most of the time. So when I get that question from cardiology, and I ask the question back, like, how about do you need the study? Like, well, he thinks I should really have it. Like, well, we will deal with the consequences. And there's some strategies that we use to minimize the risk of damage to the kidneys. One of the strategies is to bring the patient for IV fluids. You give them normal saline, like for 8 hours. I usually do like 2 hours before the contrast and 8 hours after. So the patients, they're there for 10 hours getting IV normal saline. And we also use a medicine called Mucomist. Have you guys heard about Mucomist? So Mucomist is N-acetylcysteine. It's a very benign medication. Typically, it's an antioxidant. There's some studies saying that that doesn't work, that that's just a waste of time and money. But when you think about it, the risk of harming someone versus the small benefit, I know that I'm not going to harm anyone by giving them Mucomist. So that's why I always use it. Because there's some small studies that suggest that, yes, it can still be protective. If you have a question on your boards and they give you a patient with congestive heart failure, and this patient they need to give in contrast, and he's on congestive heart failure, and they give you options. What would be the best next step in the management to protect those patients' kidneys? They're going to give you options. A, normal saline. B, bicarbonate. C, furosemide. D, aspirin, whatever. So please do not answer fluids because the patient is already on congestive heart failure. So the best way you can help that patient is by diuresing him, by giving them IV furosemide. So I think it's an unfair question, but I see it on my wards over and over. And the students, they always come to me and tell me, hey, I got that question of furosemide. So you have to give him furosemide because you want to optimize the hemodynamics in order to protect those kidneys. But contrast-induced nephropathy is pretty common in the hospital setting. And a lot of the times, acute kidney injury happens in the hospital for things that we do to our patients. So they come fine, and there's something that we do. Another classic example of inpatient acute kidney injury is when the patients develop acute interstitial nephritis. Do you guys think AIN is common, or you guys think it's not common? No, fortunately, it's not common. Yeah, I know it's on the boards, like everything that's not common, pheochromocytoma, you're going to get asked on the board. So I would say that acute interstitial nephritis accounts for about 4% of the cases of acute kidney injury, 4 or 5%. And we know that there are some agents that are very well-known, established offenders. Do you guys remember what drugs, in general, can cause AIN? NSAIDs, very good. Which one? Penicillin, very good. Penicillins are actually one of the beta-lactam antibiotics are one of the highest offenders. It's a type 4 reaction. In other words, your body needs to be exposed to the antigenic stimulus so they can mount an antigenic response. So the first time something may or may not happen, but the second time that you're exposed to it, you may develop the classic triad of like generalized rash, acute renal failure, and they may have urine eosinophils. Have you guys heard about the urine eosinophils test? That's the reason why we send the urine eosinophils, just to rule out acute interstitial nephritis. And I think the reason why they ask us about this entity on the boards is because early recognition is very important to prevent progression. If you keep giving the same drug over and over, the patients ultimately can become dialysis dependent. And the management is to stop the offending agent right away. And most patients, they do better. Some patients, they don't recover, and you need to give them steroids. But when I'm confronted with that dilemma, I usually get a biopsy because I don't want to give steroids just because I want to give steroids. If the biopsy is very consistent with acute interstitial nephritis, definitely I give steroids, and I immediately stop the offending agent. The list of AIN medications is this long, but for your information, probably your level of training, you need to know that beta-lactam antibiotics, fluoroquinolones antibiotics, NSAIDs, and PPIs are probably responsible for the majority of the cases. PPIs is another big offender in that list. You guys know that when you do a renal biopsy, you send the studies for three components. You do it for light microscopy, you do it for immunofluorescence, and you do it for electron microscopy. So when somebody has acute interstitial nephritis, the light microscopy, that's where the money is, because you're going to see a lot of lymphocytic infiltrates in the interstitium. The glomeruli, the tubules, and the interstitium is everything else. So you see massive migration and invasion of lymphocytes occupying the interstitial space. And that result, you can actually get it within 24 hours of the biopsy. So it's pretty straightforward. Just get in touch with the pathologist. Hey, you know what? I really need to find out if there's interstitial nephritis. I usually call the pathologist and give him a heads up, and I get a response the same day. And that way I can decide what I need to do. But again, to summarize, acute interstitial nephritis is common on your boards. It's not that common in real life, and typically is associated with medication, drug-induced. There's some systemic diseases that can actually be associated with interstitial nephritis. You don't need to know this for your level of training, but I'm just going to mention them. There's something called renal sarcoidosis. There's another condition called multiple myeloma involving the kidneys. And there is a group of diseases that are more and more recognized that are called, it's a group of diseases, systemic diseases. They're called the IgG4 diseases. I don't know if you heard about autoimmune pancreatitis or idiopathic pancreatitis, and now we have like these IgG related renal diseases, but they can present with a lot of interstitial nephritis. Okay, so what is the most common cause of acute renal failure? That's another take-home message. You're going to learn this, and you're never, after today, you're never going to forget this. Never, I guarantee you that. What is the most common cause of acute kidney injury?
I'm just guessing 18.
ATN. And what is the second most common cause of kidney failure or kidney injury? Not kidney failure, because that's diabetes, but kidney injury, acute kidney injury.
Drugs?
ATN.
Oh.
And the third most common.
18.
And the fourth most common. ATN. So you're never going to forget this, because ATN, it's like if you come to me and tell me, hey, you know what? He has a fever. What? Fever from what? It's the same thing. Your job as a nephrologist is to identify why this person has ATN, because the ultimate pathway of a lot of these injuries is ATN. You have hypotension? Guess what? ATN. I gave you contrast? Guess what? ATN. This person developed rhabdo? Guess what? ATN. So, and ATN is just destruction and sloughing of the tubules. You guys remember from renal anatomy that we have the cortex and we have the medulla. So if you want to do a biopsy, it's because you want to biopsy the cortex, the most external layer of the kidney, because that's where the money is when it comes down to looking at the glomeruli. If you end up getting medulla, you have a bunch of millions of little tubules that are interconnected, and they usually drain into the renal calyx, the renal pelvis, and the renal pelvis drains into the ureter, and that forms the urine, right? So the tubules actually, they get damaged by multiple different reasons. In a hospitalized patient that actually underwent surgery, you always have to think about rhabdomyolysis, always. So have you guys seen a case of rhabdo? Ever? Okay, so in your boards, they may give you somebody that was actually having a status epilepticus, like the one I described, or they may give you a patient that was running a marathon, or they may give you a patient like the one I had when I was at UCLA. A woman was treated, she had H. pylori, and she was taking diltiazem for blood pressure, and she was given clarithromycin for H. pylori gastritis. So she took diltiazem and clarithromycin and a statin. She was taking simvastatin 80, clarithromycin, and diltiazem. That was a really bad combo. That was a horrible combo. And you know, the physician failed, but also the pharmacist failed, because remember, the pharmacy, one of the main jobs of the pharmacist is to identify potential hazard interactions. And I really appreciate the work of the pharmacist in my day-to-day practice. I've seen that some of my colleagues, they get upset when they call me, like, oh, they're calling me again. You know, my advice to you guys is have very good relationship with everyone in this business. And they saved my butt in the past, because they've been able to pick up things like I didn't know. Like when I prescribed that Cipro on that patient, myasthenia gravis, I wish the pharmacist would have stopped dispensing this medicine. The pharmacist also failed. We're humans. We're in a job where you're going to make mistakes, guaranteed. But the pharmacist is one step into the safety net that we have for our patients. So when they call you, listen to them, don't ignore them, acknowledge and respect. If they have recommendations, acknowledge it. And just say, okay, thank you very much, let's change the dose to this and this. So this person that I'm describing, unfortunately, these three combination drugs were horrible combinations. She went into severe rhabdo, she went into the ICU. Her calcium was like undetectable. It was the craziest thing I've ever seen because of sequestration. Her CPK was like in the 100,000. They stopped measuring after so much because they do dilutions. You know how in the lab they dilute, they measure, they dilute and they measure. It was already like I already diluted to 100,000 times, and still they found CPK. So the lady made it, fortunately, but it's probably one of the most severe rhabdo cases I've seen. So if you have a patient post-operatively, I had a consult one time. I was the attending at Oliveview. The patient came up of surgery, urine output dropped. The easy thing to say is like, oh, maybe intraoperative hypotension, ATN. But the reason that this guy actually went into renal failure is because one of the extremities got caught in an awkward position when the patient was recovering from anesthesia. One of the CNAs actually saw that the patient's leg was trapped. They documented there, blah, blah, blah. And that was enough. Who knows how long the extremity was there for? That was enough to cause severe rhabdo. And this patient actually went into renal failure. So every time you get consulted in the hospital, you check a CPK. Simple, sweet, and you will be able to pick up. And why is it important? Because how do we manage rhabdomyolysis? You guys know? How do we manage it? How do we treat rhabdo?
Take the offending thing away.
And how do you take the offending when it's myoglobin circulating in your blood? How do you take it away?
Like some kind of exchange.
I'm sorry? No, it's actually great. So dialysis is not very effective removing it. So we try to remove it by forcing diuresis. So if the patient makes urine, it's a blessing because we can give them something crazy like 200 or 300 cc's an hour of saline, normal saline. And you force diuresis so you can clear up all the myoglobin. Remember, it's pigment, it's fluid, saline.
The treatment for rhabdos,
Fluid. It's like forced diuresis. You give them like a tremendous amount of fluid. Before, some doctors are still doing this, and I don't endorse that. They're giving bicarbonate solutions because some studies suggested that bicarbonate, alkalinizing the urine was superior to increase the myoglobin excretion in the kidneys. Like, I don't believe in that because the same results are, with good quality studies, the same results are obtained when you give a lot of normal saline. And the problem is when you alkalinize someone, when I say alkalinize, is basically you're combining bicarbonate with sterile water, and you make it isoosmotic. You know, like what's the serum osmolarity? Do you guys remember? What's the serum osmolarity? Serum osmolarity, not the pH. 280. So normal saline, what's the osmolarity of normal saline? It's 154 of sodium and 154 of chloride. It's about 300, 308, right? So when you give a isotonic, when you give a hypertonic solution, that means that it has a lot of like sodium or bicarbonate on it. So to make it isotonic, you give 3 amps of sodium bicarbonate. Each one is about 50 milliequivalents of sodium bicarbonate. So you put 3 amps in 1 liter of normal saline. 3 amps in 1 liter of sterile water, and that makes it isotonic. And you start running it like 100, 200. The problem is that you need to know what you're doing. You need to know what you're doing if you give bicarbonate. Because if you don't pay attention to the calcium, what happens if you have a lot of bicarbonate? What happens to your calcium?
You have a lot of bicarbonate?
Becomes very low. Hypocalcemia. So you can kill someone from hypocalcemia. And I always see oncologists like giving bicarbonate solutions. Like the other day, a guy combined normal saline with 3 amps of bicarbonate. The osmolarity of that is almost 500. And he was just giving it to a patient, like running like 300 or 200 cc's. So they called me because the sodium was 160. They're like, what? You gotta stop these IV fluids. That's basically, this guy's gonna have a bad complication. So that's the reason, another reason why I don't like it, because most physicians, they're not experienced with what to expect if you give bicarbonate. And the data shows that it's effective and perhaps saline is superior. So you give tons of fluids, bombard them with fluids. If they're still peeing, you can keep doing it. If they stop peeing, no good. You need to stop the IV fluids, otherwise they're going to go into pulmonary edema. And you need to dialyze them.
What's the most common cause?
From rhabdo, it's probably trauma. Like crushing like earthquake victims and stuff like that, or like a crushing trauma.
So, if you gave that bicarbonate and saline solution, and do you just monitor the calcium?
You have to monitor the calcium, and you have to monitor the potassium, because
when it drops, you just stop
No, you have to give replete. If you still need to use it, you need to replete aggressively. And the same thing happens with the potassium, because remember, potassium is primarily an intracellular ion. And if you alkalinize, what happens is that potassium goes in the intracellular space, and patients can have symptomatic hypokalemia. So you have to, when I was attending neurology, we got consulted on a case. The patient coded. We got him on board after the patient coded, but there was a patient with HIV enteropathy, and he was, failure to thrive, profoundly malnourished. He came in with a potassium of 2.7 and a bicarbonate of 12. So the attending of the team, he failed to recognize that the most important electrolyte abnormality was not the potassium of 2.7. The most abnormal abnormality was the fact that his potassium was 2.7, and he started alkalinizing the patient. He said oh, bicarb of 12, that's very low, so let's put this guy in a bicarb drip. So guess what? The minute that it hadn't been 2 hours since he started doing the bicarb, the patient coded, and he made it. But the next potassium when they measure was 1.8. So that's why you have to be very careful. The potassium is the most low potassium is as bad as fatal as high potassium. It's an electrolyte abnormality that you cannot ignore. Okay, so that's how we manage rhabdo. So again, easy to diagnose, is not as easy to treat, but if the patient is making urine, you have some room to play with the patient, like we're going to learn later in this case. And so take home messages, most common ATN, 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 ATN. Can you have an RPGN while in-house? Yeah, you can also go to Santa Monica and get attacked by a shark, but how likely is that to happen? It's very unlikely, right? Same thing, like patient developing a rapidly progressive glomerulonephritis, very unlikely. And if we have time this week, I'll cover the GNs, because that's something that you need to know for your boards. But GNs are primary diseases of the kidney. And we're talking about a guy who came in with near normal or normal renal function to the hospital and developed acute kidney injury. So chances are we're dealing with obstruction, we're dealing with interstitial nephritis, or we're dealing with ATN. And when you say ATN, remember, it's like if you're telling me I have a fever from what? ATN is ATN from what? And on your boards, what's the name of the cast from ATN? Muddy brown. So if they show you the picture, you already know it's muddy brown. Your job is to identify why. Why do we have muddy brown cast? And there's many different reasons why. Okay, why don't you read the second paragraph for me so they can move on.
Patient denies symptoms of congestive heart failure, has not been extremely thorough.